Dr. Tracy Barico, welcome back. How are you?
Hey, Kathy, how are you? I'm so grateful to do a third episode. I love the fact that women are asking questions. This is amazing.
Everybody has been like, oh my gosh, when are you having Dr. Miracle back? I mean, I know I named you Dr. Miracle. That's not your given name. But Dr. Tracy Barico has saved my sanity through menopause. I thought I was going to lose my mind between being over hot and ready to stab somebody. You've done a public service by coming to Coffee Talk and talking about all things menopause, hot flashes, HRT, all the things. And I am very grateful. My audience is very grateful. But here's the thing. The gossip, rumor, and innuendo community is giving back. Instead of airing this video on my channel, we're doing this exclusively on Dr. Tracy Barico's channel. So if you are watching this, have you hit the like button yet? Have you hit the subscribe button? Have you shared this with your girlfriends who are hot and stabby? That is what you need to do. So just so that you know, you can find Dr. Barico at Dr. Tracy Barico here on YouTube and all other socials. What other socials are you on, Doctor?
Pretty much all of them: Facebook, Instagram, LinkedIn, TikTok, you name it, I'm on it.
You are everywhere. Oh my gosh. The most important thing, though, is we need those subscribers. We are trying to get Dr. Verico to 1,000 subscribers. She's like this much short. So listen, before you go anyplace else, before you hear one other word from my mouth, hit the subscribe button, please. Let's get Dr. Verico to 1,000 subscribers. We're going to get there together. Like, subscribe, share, hype, all the things, all the things. Okay. So, if you have not already, parts 1 and 2 of this Coffee Talk series about menopause are part 1 is on my channel. You know what? I think we'll move it to your channel, Doc. We'll put it over by you so people can see everything in one place. So, we'll have part 1, part 2, and this is part 3. A lot of people had questions following our last series about all things women's health, HRT, menopause, all the things. Some of the questions were a little bit out there, but I've written down as many as we could capture, and we'll see what we can get through today. You ready?
I'm ready. Bring it on.
Okay. So, is there an age limit to when you can start HRT? And this particular questioner was asking, listen, I'm over 50. I feel like the whole menopause thing is past for me. That's all in the rear view mirror. But what if I find I'm having symptoms? Is there an age limit to when you can start?
There is absolutely no age limit. So, some of this idea that there's an age limit to when you should start or stop hormone replacement really stemmed out of the Women's Health Initiative study in 2002. And it was mainly based on use of oral estrogen, which, again, if you saw the other videos, oral estrogen can increase the risk of a clotting event only by 1%. It's a very low risk. However, it's there. However, we're using topical estrogen replacement now. So we do not see any clotting events at all with topical estrogen formats. So it is completely safe to start anytime, and there is no age limit to when you need to stop hormone replacement either. We do have data that shows if you start hormone replacement therapy within the first 10 years of being menopausal, and remember, the definition of menopause is 12 months with no menstrual cycle. So if you start hormone within 10 years of that event, we see the biggest benefits in terms of reduction in morbidity and mortality, bone health, dementia risk reduction, cardiovascular risk reduction, diabetic risk reduction. But again, if you start 10 years outside of that window, it's not to say you may not see benefits still. So again, this is an individualized discussion that needs to happen with your healthcare provider. Again, this whole video series is about education. This is not about individual care or treatment. You need to have these discussions with your physician.
And at least you're giving people information that they can go talk to their doctor about. It's like, hey, I saw this amazing doctor and this really adorable gossip online. And let's talk more about bone health and risk and all of these other things. I know a lot of people in our last videos were like, I'd always heard that HRT was so scary. And you explained before about the studies that was based on and how basically that's old science. Is it junk science at this point, or is it just sort of not well understood information?
So it's really more about the framing of how that information was disseminated. It really was not
Mm,
disseminated accurately. So the data is excellent that we have. It's very supportive in that the benefit of hormone replacement therapy for many, many women probably outweighs the risk of anything adversely happening. Everything we do in medicine has a risk benefit ratio, but the benefits with hormone replacement therapy far outweigh any of the risks that we see, like clotting events or breast cancer risk. Again, when the information was disseminated, they grossly overestimated or disseminated that there was this huge risk in breast cancer, and it scared the
mm,
bejesus out of a lot of women. I mean, I don't know a
right,
single woman that would sign up for a slightly increased risk of breast cancer. But when you look
right.
at the number was never shared with the general public. It was a 0.08% risk of breast cancer with a specific type of progesterone, and they blanketed that progesterone to apply to all progesterones, which are not accurate, not fair. So again, we're unwinding
Oh.
a lot of how the study was presented to the lay public and even other physicians.
I know a lot of women are curious about sort of the links between postmenopausal bleeding and progesterone. Like, can you help me understand that a little bit?
Yes, bleeding is a hot topic. So, the number one presentation in perimenopause is irregular bleeding or irregular periods. So, what does that mean? Well, it can mean anything from your period frequency is coming closer together. So, you're bleeding every 3 weeks instead of every four,
Oh,
or it's farther apart. So I even have some people that are bleeding every 2 weeks or almost every day of the month. And obviously, that is not
uh,
fun, right? We
yeah,
also
no.
see changes in the amount of bleeding that you're experiencing. So it can be less frequent and also lighter, or it can be more frequent and lighter, or we see much heavier bleeding. And that's also very common, to the point where people are, bleeding through clothing, having accidents, becoming anemic, needing blood transfusions because they're bleeding so heavily. That is
Oh,
not
wow.
normal. And so I always tell patients, be vigilant, pay attention. If you start seeing some of these trends where you're soaking through a pad or tampon in less than an hour, you're passing clots that are large, you're feeling fatigued, dizzy, lightheaded, short of breath, those are warning signs. You need to go see your gynecologist. And there are things we can do to help with your bleeding during this transition. Why does this bleeding happen? It's mainly because there's many things happening at the same time hormonally, one of which your progesterone levels are starting to decline. And progesterone
Mm.
stabilizes the lining in the uterus. It keeps the lining well controlled, stable, and allows for release of the lining in a very controlled manner. So when you're losing progesterone, the uterus just releases whenever it wants to and however quickly it wants
Oh.
to. And that contributes to heavier bleeding. So frequently, when I put patients on progesterone, their bleeding gets better. The other thing that's happening hormonally is your estrogen levels are wildly fluctuating. They're high, they're
Mhm.
low, they're in the middle, and they look normal at times. And estrogen's role in the uterus is to make your lining grow. So, obviously, if you're getting wildly escalating estrogen levels, your lining is growing uncontrollably at times, and that contributes to more lining to shed. And so, therefore, your periods are heavier. So there's a lot going on here hormonally that's affecting cycle frequencies and cycle release and bleeding. And it is very treatable and very controllable. We use all sorts of medications, different birth control methods, IUDs, for example, which are intrauterine devices that are impregnated with progesterone. And it really helps patients for quality of life. I know that one of the questions we got was surrounding, what about using an ablation procedure to treat my menopause symptoms? Great question.
Yes.
So,
Yes.
when patients fail medication treatment to control bleeding, there are surgical treatment options. And an ablation is a surgical treatment option where we cauterize the lining in the uterus that you're shedding. And for most women, it works really well at reducing bleeding, sometimes to the point where they have no further menstruation. It doesn't affect your hormones. It's just affecting your lining in the uterus. That's it. And so it's an easy same day procedure, has very low risks to it overall. You do want to make sure that someone has tested your lining to make sure there's no cancer cells before having this procedure done. And I generally recommend to patients in general that whenever you have abnormal bleeding, your lining needs to be evaluated to rule out uterine cancer. Uterine cancer incidence starts to really rise from 50 years of age and older, but it can even present itself in your 30s and 40s if you have certain medical risk factors. So that is part of the workup. So I'm always telling patients, if you're having abnormal bleeding, you've got to go see your gynecologist and get the proper workup and rule out some of
Mhm.
these other things before we blame it just on hormone.
Ah, that was so much good information. And one of the things that I read about with getting the uterine biopsy, everybody was like, "It's horrible, it's horrible, it's the most terrible thing that ever happened in my whole life." And I was like, "Okay, I gave birth 3 times, so I don't
Yeah.
so where are we on pain? Because 'Cause I'm a real big chicken doc, and I'm like,
Yeah,
if
I
it's
get
gonna
it.
hurt, I might not wanna do it."
And, I always tell patients, like, be careful what you're reading and listening to. Everybody's pain tolerance is different. No doubt, my first thing to patients is I'm not here to torture you. Okay. So
Right.
we want pain management. So there's lots of things we can do when you're coming to the office for a biopsy in the office. And it is crampy. I've had it done, but I feel like I have a fairly good pain tolerance. I all I needed was some Motrin and Tylenol an hour before the procedure. It was a little crampy at the moment of the procedure being done, and then I was able to get up and walk out of the office and go back to my day. But everybody's pain
Okay.
tolerance is different, and so some women need more than just Motrin and Tylenol pre-treatment. But there's also things that we can do technically to reduce your pain. So, what I basically do is read the patient. If the patient has a very low pain threshold, they're very anxious, I'll say, listen, we'll try to do this in the office, but I'm not going to torture you. If at any point in time you're really uncomfortable or there's something, you want me to stop, you're in control. And we can always do this under, light anesthesia in an operating room
Okay.
setting where you're not going to feel a thing. So again, I hear this all the time. Remember, you know, you only hear the bad things. You never hear the good things from patients, right? They're
Yeah.
only posting their bad experiences. So I always say, temper what you're hearing, have the discussion with your doctor that you have this fear, and let them, pre-treat you with something to help with the pain. Sometimes I'll even use some medication that helps open the cervix a little better so it's not so uncomfortable. So again, there's a lot of different things that we can do for pain management.
Okay, that is good to know and good information for me personally. Um, Osteoarthritis and HRT, does one cause the other? Does it help the other? We got a question about that as well.
Yeah, so our osteoarthritis is wear and tear of the joint, which causes
Hmm.
bone spurs or loss of the collagen and cushion tissue that is in the joint. Hormone replacement therapy doesn't cause arthritis, wear and tear, but it does cause something called musculoskeletal syndrome of menopause, where estrogen is an anti inflammatory for the joints. So when you lose estrogen, we see more joint inflammation, not
Mhm.
necessarily wear and tear, but you will see more stiffness, more achiness, not as much flexibility. And that's where we see conditions like frozen shoulder, hip pain, back pain. Those conditions are directly tied to low estrogen in women. And so when we treat women with systemic estrogen, we find that those conditions resolve and their pain resolves. And so a lot of times you may be going for physical therapy because you've developed this joint pain. And if you're hopefully your physical therapist is well versed in the menopause space. And so if they're saying to you, hey, you may want to go talk to your gynecologist about getting on some estrogen, it might help this, they're right. And so in the orthopedic literature, we have a ton of excellent studies showing estrogen is a benefit for the joint, not going to prevent arthritis, wear and tear,
Right.
but it will prevent inflammation, stiffness, and conditions like frozen shoulder, which is an inflammatory condition.
That's so interesting. It was only when I started looking into menopause more when I had symptoms that I saw people talking about frozen shoulder. And I was like, I've never heard of this craziness, but that makes a lot of sense to me. Another
Mhm.
big one that people were talking about was postmenopausal UTI. Now, someone had a question specifically about Premarin. I don't know how do you pronounce that word.
Yes, it's
Premarin?
pronounced Premarin. Premarin is just the
Okay.
brand. It's a brand name of estradiol estrogen, which is the main estrogen we're
Okay.
using systemically as well as vaginally. So again, if you saw some of my other videos, this is called genitourinary syndrome of menopause. And it's a collection of symptoms whereby women develop low vaginal estrogen or low bladder estrogen state, which then causes symptoms for them. Anything from itching, burning, irritation, frequency of urination, more leakage of urination, tendency to get bladder infections. There are tons of receptors for estrogen in the bladder, the vagina, and the urethra, the tube you pee from. And so, what we know, and we have excellent studies on this, is that it is very treatable with vaginal estrogen. So, we treat with direct vaginal estrogen in the form of estradiol. Premarin is a
Hmm.
brand name. In my opinion,
Okay.
you don't have to spend a lot of money. Premarin's expensive. It could be like $125 for a small tube. If you get
Oh my gosh.
generic estradiol, it's like $35. Very cheap, very effective, not any necessarily better than Premarin. And it comes in a cream format that you apply to the inner vagina. And I even have some patients apply a small dollop to their finger and rub it on the labia and near the urethra and the vaginal entrance once per day. And this drastically improves blood flow to the region, helps with tissue elasticity and collagen, helps with lubrication, and greatly improves their symptoms. And we have a large study that was released in 2025 by the American Urologic Society showing a 50% reduction in urinary tract infections. As women age and are elderly, they're more prone because of this
Right.
condition. And there's an actual reduction by 50%, which is huge if you use vaginal estrogen. So if you know any older women there that are complaining of frequent urinary tract infections, either without intercourse or after intercourse, and even younger patients who may have low estrogen levels as a result of using birth control for a prolonged period of time, they benefit
Mhm.
greatly from vaginal estrogen.
It's wild. I feel like every time we have a conversation, I'm like, "Wait, I didn't know this thing, I didn't know that thing." There's so much to
There's
learn.
so much. Yeah.
So, it's a mountain of information. I'm so glad you're here.
Mhm.
Okay, somebody asked a question, and she said for insurance reasons, she was off of her HRT for 4 years. Can she go back on?
So that's a great question. I guess the question is, why did she stop to begin with? Was she having side effects? Was there a contraindication to her continuing hormone replacement? So it might be a little hard for me to answer directly, not knowing the full history. But I do have
I
some
mean, she said
patients that,
insurance. She said it was the cost, that it was just a money thing, based on the
yeah,
question that was submitted.
right. So if it was just cost related and there were no health contraindications for any reason, then I would say you certainly could resume use. Again, you're going to reap the most benefits if you're resuming it within 10 years of menopause. Again, you might still get some benefit even if you're outside that 10-year window. But again, it just depends. It's an individual conversation with your doctor about why do you want to resume? What kind of symptoms are you still having? If you're having moderate
Right,
to severe symptoms, then I would be in full support of you resuming. There's no reason why you couldn't necessarily, again, depending on your health history. But if you're
right.
for some reason not a candidate for hormone replacement therapy any longer, remember we have other non hormonal medications that we can offer you that are very effective in treating symptoms.
Awesome. Now, one of the other questions we got was HRT for severe pain, which makes me think maybe that's that musculoskeletal whatever you were talking about.
Yeah, it sounds like that's what the question is surrounding. So, again, if you're having a lot of body aches, body pain specific to joints, yes, it could very well be from estrogen being too low in the body, and replacing estrogen may be greatly helpful. I mean, I suffered from terrible hip pain to the point where I was
Mm.
ready to buy a new mattress. I was going for, exercises and PT to try and unwind it. And it ultimately wasn't really, that wasn't the problem. It was the estrogen. And once I started estrogen, it completely disappeared for me, which was amazing. However, there are a lot of reasons for joint pain, and you really need to have your primary doctor looking into other things like autoimmune conditions, because we do see things
Mm.
like rheumatoid arthritis, Sjogren's. There are different things in the autoimmune sector. If you are in a state that has a very high risk for Lyme disease, like New Jersey, get your Lyme tested,
Oh,
because that can cause joint problems. So again, we don't want to get tunnel vision and blame everything on hormone here. We want to make sure we're
right.
ruling out other health conditions.
Good to know. What about the relationship of mental health diagnosis and HRT? Because I know there's like some mood stuff that happens. So
Mhm.
that was our next question, mental health diagnosis with HRT.
Yeah, this is huge. I will tell you that the studies show 70 to 80% of women who are going through perimenopause and menopause experience mood disorders. 70 to 80%. What
It's
is
a
a mood
lot.
disorder? That's a lot of people, right? So, a mood disorder is defined as feelings of depression, depression symptoms, anxiety, panic attacks, irritability, mood swings like PMS, Jekyll Hyde feelings,
Hmm.
crying
Hmm.
spells, short tempered anger, low frustration tolerance. That kind of gets all lumped into mood disorders, right? So, again, we don't want to have tunnel vision. Not everything is hormonal. Maybe you did have an
Right.
underlying diagnosis of anxiety and depression. Maybe you have bipolar. Maybe, you have some kind of mental health disorder that maybe never got adequately addressed. And menopause or perimenopause is bringing that to the forefront even more so.
Hmm.
Go
Hmm.
see a healthcare provider in the mental health space, whether it's a therapist, a psychotherapist, a cognitive behavioral therapist, a psychiatrist. You need to get a proper diagnosis. However, I do see a lot of patients get misdiagnosed and get labeled as depression or anxiety and given an antidepressant or an anti-anxiety medication, when it really is more, the root cause is hormonal. And again, progesterone is what I call nature's Xanax for women. It keeps you feeling calm and relaxed, and you can sleep better with it. And estrogen also affects the brain greatly in terms of cognitive function. So if we replace these hormones, many women report a significant improvement in their mood symptoms. And so sometimes I feel like that should be the first thing we should try treating. And if the patient is then
Yeah.
still struggling, then they need the proper diagnosis and treatment.
Good to know. And now, in the course of this conversation, we've talked a lot about estrogen and progesterone. Are there other hormones out there that people need to be aware of or get tested for or anything like that?
100%. There's so many hormones involved in play here. One I think is really important to touch on is testosterone for women. Women make testosterone just like men. We just don't make as much as men do. Men also make estrogen. And so in the testosterone space for women, testosterone acts very similarly in our bodies like estrogen. So we see things like cognitive impacts if your testosterone is low. Testosterone naturally declines as you age, but for some women,
Right.
it plummets very early. And so, about a third of women have extremely low testosterone levels where they would benefit from treatment for all the symptoms that they're experiencing. So, again, low motivation, no energy, feeling exhausted all the time. Fatigue is one of the top symptoms of low estrogen and low testosterone.
Mm.
Obviously, libido is affected, just like with estrogen. If libido is low, it could be estrogen or testosterone. We also see bone loss and muscle loss with both estrogen and testosterone. So it can affect your bone loss and osteoporosis risk if it's left untreated. And so a lot of times when patients are low in testosterone, they will feel better on estrogen. And when I'm speaking to them about, tell me what your follow-up symptoms are after we've treated you with estrogen, they're like, I'm better, but I always hear the but.
Mm.
I'm still a little brain foggy. I still have no motivation. I have no energy. I'm tired. And sure enough, their testosterone, once it's replaced, they come back after testosterone treatment and they're like, okay, now I'm better. So again, if no one is checking testosterone, they need to be checking, because it is an integral part for some patients, I would say about a third, and really important for treatment to, be on testosterone. We typically, there's many forms of testosterone. Typically, I'm using a topical testosterone. I think the limitation right now is there aren't a lot of products out there for women. There's none other than injectable. And so we are actively petitioning the FDA to come out with a testosterone strength that's appropriate for women. Right now, we're having to use the men's dosing at a tenth of the dose in order to not
Oh
overtreat
boy.
patients. Yeah. So again, you need to be seeing someone that's well versed in this space and understands how to prescribe testosterone, what strength you don't want to overtreat.
One of the most important questions, I'm looking at the time, we're about done, but one of the most important things you taught me was the time horizon, because I was like, if I start taking hormones on Monday, I should feel better by Tuesday. What turns out that's not how that works, sadly. What is the time horizon that people can expect to sort of start to feel a little bit better if you're feeling hot and stabby like I was?
Yeah. So I tell patients you want to give any dose of hormone a minimum of like 8 to 12 weeks to really kick in fully. Now, that's not to say you may not see improvement within the first couple of weeks. I know with lots of patients, once we put them on estrogen and progesterone, they will come back and share with me that within a couple of weeks, their hot flashes were much better and their sleep was much better almost immediately within the first 2 weeks.
Mhm.
But I do see patients continue to improve in their clinical symptoms as they approach weeks 8 through 12. So I always tell patients, don't panic and think, oh my gosh, this is not working. Or if you get side effects, and we can do a whole nother video on side effects of HRT, but give it time, give it a chance to do its job fully. And sometimes the symptoms that you get that are side effects in the beginning will disappear as you're on your medication for a good duration. So give it
Hmm.
8 to 12 weeks, and then we reconvene. And that's when I'm typically meeting with patients, is at the 12-week mark, to say, okay, you're now fully therapeutic at this dose. If you're still having symptoms, then we need to make an adjustment.
Okay. So don't start today and expect results tomorrow.
I
That's
know.
my
I wish
favorite.
I wish there was an easy button. There's just not.
We'll have to ask the FDA about that as well. So, look, this is so amazing and so informative. When can we expect to see you again next, Dr. Tracy Barrico, with more information?
Yeah, so I'm going to post another video every Sunday. So join me that time. I'm going to, make sure we continue to push out education and evidence-based information for you so that you're not confused and thinking that what you're hearing on social media and things, there's so much noise out there and you don't know who to trust
Yeah.
and who to listen to. So every Sunday, we're going to have a video out for you. I will put shorts out also just for little short, brief things. But, if you can follow and share with all your girlfriends, the more women who understand and know this process, the more empowered you will be, and you can advocate better for yourself and really get the care you deserve.
Absolutely. This has been so powerful and so amazing. I'm so, so grateful. But listen, for everybody who's watching, if you still have questions, if there are more things you want Dr. Verico to talk about, drop those
Yeah.
questions in the comment section of this video. After you like, subscribe, share, and hype, and to show that you watch this video all the way to the end, put a stethoscope or your favorite medical emoji in the comment section. Thank you so much, Dr. Verico, and I will see you next
Thank you.
Sunday right here on YouTube.
Thanks, Kathy.
Bye.
Bye, everybody.